Thank you very much, everyone, for tuning in wherever you are, and hope you are staying safe. Thank you to the organizing committee and the chairperson for the kind introduction. Today, I'll be talking about controversies involved with bowel preparation, and I will be glad to take any questions at the end of the symposium. The outline of my talk would be a brief introduction to the indications of bowel preparation, how bowel preparation was used in history, and how controversies came out fairly recently on the use of it, the different types of bowel preparations available, and also the pros and cons of using bowel preparation, which leads to the current controversies. And I will obviously present on the scientific evidence for and against the use of mechanical bowel preparation. From the 1890s to about the 1970s, bowel preparation, or what we call as MBP, or mechanical bowel preparation, was the standard treatment for patients undergoing bowel surgery. The belief was that by cleaning the bowel, it would contribute to a reduce in bacterial load, therefore less chance of infection of not only at the wound, but also a less catastrophic anastomotic leak. But it was in the 1970s that people started to question whether mechanical bowel preparation was indeed really necessary. Probably also because of that, at that time, the bowel preparation that we use caused many other complications like electrolyte imbalances, dehydration, for example. So Hughes et al. In 1973 came up with this landmark paper which questioned the use of MBP. And what he found was that patients who had no MBP or no bowel preparation were really not more at risk of septic complications compared to those who had it. So he was really challenging the beliefs at the time. The reason for all this, especially now, is that with better broad-spectrum antibiotics, improved anesthesia, and the use of minimally invasive surgery, laparoscopic surgery, has brought significantly the rate of septic complications. So therefore, the question is, do you need to risk using mechanical bowel preparations to further reduce it, since it's already, since the rate of septic complications, of course, depending on the surgery, is relatively low. In fact, by the first decade of this century, most surgical societies recommended that we don't need to use mechanical bowel preparation. And this was generally accepted until about 5 or 6 years ago, when the Americans came up with a study or a survey, an audit of about, and I will share the studies later, a very, very big group of patients. And really, it was this data that really ignited the debate on whether we should or should not use mechanical bowel preparations. I will go into this later. So at the moment, there's really a divide between the Americans and the Europeans with regards to the use of mechanical bowel preparation. The American Society of Colorectal Surgeons has suggested the use of mechanical bowel preparations and oral antibiotics, or I call it here OAB, as the standard of care for every patient who undergoes a colon or rectal surgery. Whereas the Europeans have gone the other way and have stuck to the belief that you really don't need mechanical bowel preparation, especially in the colon. And if you are to use it, it's only really for the rectum, and you always combine it with oral antibiotics. So if you look at the literature, there is so much out there that a person who is interested in finding out what is the best or ideal will be quite confused. Should you use bowel preparation alone? Should you not use any bowel preparation? Should you combine it with antibiotics? And if these antibiotics, should you combine it with oral antibiotics or with systemic antibiotics? Or why don't we just not use bowel preparation and just use antibiotics alone? And if you decide to go along that path, should you just use oral antibiotics or systemic antibiotics or both? So really, there's so much out there. There's a lot of practices varying from different countries, from different societies, from different individuals. So essentially, this is what makes the decision to use mechanical bowel preparation or not a bit more difficult. So moving on, I have to talk about colorectal cancer because I'm a colorectal surgeon, and the general use of mechanical bowel preparation is almost always for a malignant cause. So colorectal cancer is a worldwide problem. And in Malaysia, it is the second most common cancer overall. It is the most common cancer in men and the second most common cancer in women. So it is an increasing problem, and therefore surgeries that involve colorectal cancer is getting more and more frequent. Unfortunately, our cancers present a little bit later, which is either stage 3 and stage 4, and that is because we do not have a compulsory national screening program. And the whole reason why we want to screen these patients earlier is so that you can catch the cancers earlier. And by doing so, increasing the 5-year relative survival. And the only way you can catch the cancer earlier is by doing a colonoscopy. And the only way a colonoscopy can be effective is really to have very good bowel prep. And the 3 key quality indicators of colonoscopy is a cecal intubation rate, meaning is the person doing the colonoscopy able to reach the cecum, which is near the appendix, and also the polyp detection rate. So if you have a poor bowel prep, the person will miss a lot of polyps and may not even complete the whole colonoscopy. If you have good bowel preparation and the patient is compliant, then you will get something like this in U1 of Boston 3. So with poor bowel prep, you might miss a polyp or an adenoma in up to 28%. And what that means is that in a quarter of patients, you will miss a possible pre-malignant lesion. So what I've shown here is that with the use of mechanical bowel preparations in colonoscopy, there's really no controversies. So then why is it a controversy when it comes to surgery, particularly colorectal surgery? Why are there controversies? Now, before I answer that question, let's look at the general concepts in colorectal cancer surgery. When we perform a cancer surgery, we always remove the affected bowel together with the lymph nodes and the blood vessels that supply that part of the bowel. So if you have a tumor on the right side, then you will remove the right side of the bowel, and that's called a right hemicolectomy. And if you remove the left side of the bowel, that's called a left hemicolectomy. And if you remove the end of the colon or part of the rectum and you join the 2 bowels back, that term is called the anterior resection. And once you remove that part of the bowel, what you have is really 2 ends, right? So for example, you have a left hemicolectomy and you have to remove part of the transverse colon and part of the descending colon. And what you have is the specimen that is removed, and you have 2 ends of bowels here. Now, what do we do? Well, the surgeon would then anastomose the ends of bowels together. Either he can stitch or he can use a surgical stapler. Similarly, if we operate on the rectum, and if you can imagine that there's a tumor here and the rectum has been removed, then you join the bowels back and we use a surgical stapler, right? And now that you understand the general principles of surgery on the colon and the rectum, let's look at the type of bowel prep. And then I will go to tell you really what are the pros and cons of using mechanical bowel preparation in colon cancer. Now, the perfect bowel preparation is a preparation that rapidly and reliably cleans the colon of all fecal material. And as I showed the picture earlier, what you want is no feces at all. all right? It must have no effect on the gross or microscopic appearance of the colon. It should not affect the anatomy of the colon, all right? And it should ideally be given in a very short span of time with very good evacuation, no patient discomfort. It doesn't cause any fluid or electrolyte imbalances. And it should be palatable, which means that it's not too disgusting to eat for the patient, okay? And it has to be inexpensive. However, as of today, there is really no bowel preparation that is perfect. As of today, there are really a few categories of bowel preparation. One is an isoosmotic solution and the other is hypoosmotic. I won't mention about brand names. I think we're all quite familiar with what's out there. But essentially, what it means is that in a hypoosmotic solution bowel preparation, the solution that is taken by the patient is so hypertonic that it draws fluid from the intravascular space into the bowel. And what that would result is that you're actually flushing the feces out with your own fluids. So it's very important in these patients to keep hydrated, because what will happen is that if you don't, then these patients will have a fluid flux and they could be very dehydrated and also have electrolyte imbalances due to all the electrolytes and fluids coming into the colon. Therefore, hypoosmotic solutions, while you don't really need too much volume, a bit more palatable, faster to take, but it does have the risk of causing fluid shifts, and that's not good for patients who have cardiac problems or renal problems. The more common solutions are the isoosmotic solutions, which we do not disturb the fluid movement in the body. Basically, it's a solution that when you combine with a large amount of water and you drink it, this isoosmotic solution stays in the colon, and it is the amount of fluid taken together with the solution that flushes out the feces. So that's why it's important these patients take about 2 to 3 liters of fluid, because it is this fluid that they drink that will flush out the feces. So they don't need to worry about using their own bodily fluids to flush out the feces, right? So that brings us to this very important slide here on the crux of it all. The proponents of mechanical bowel preparation says that if you use MBP, it will improve detection of lesions during colonoscopy. Now, that's a no-brainer. I think that is something that has no controversy at all, as I mentioned. The controversy is that also these same proponents say that in colorectal surgery, if you give MBP, you actually reduce the fecal mass and the bacterial count, and this would result in surgical site infections, including anastomotic leakage. The opponents of MBP, it says that, as I mentioned earlier, depending on the type of bowel preparation, can cause electrolyte imbalances, dehydration, right? It doesn't really reduce the flora, the microbial flora load of the bowel. In fact, what it does is that it causes the stool to be liquefied, and therefore, if there is a leak, an anastomotic leak, a liquefied stool leaking out is harder to contain than a solid feces. Then that's the belief. Also, it is uncomfortable for the patient, and it can lead to a higher incidence of Clostridium difficile infections, especially when you add it with antibiotics. So this brings us to this slide again. Which one should we choose? Now, if you look at all the studies out there, they basically look at comparing the different modalities, like I mentioned here. Either the studies compare no MBP with MBP, or with MBP with antibiotics or not. Okay, but what are the outcomes generally they're looking at? Is the evidence of surgical site infections, whether it's a superficial, deep, or organ space, with the incidence of anastomotic leaks, whether using these bowel preparations causes an increase or a decrease in the length of hospital stay, and also what are the mortality rates. And as I mentioned earlier, there is a American-European divide, and we in Asia really in the absence of hard evidence of our own, generally have to decide which one would we want to use. Now, it is this data that came out from the United States in 2015. They were looking, and this was on the left here, their preliminary results, looking at about 5,000 patients. And they were looking at whether if you combine mechanical and oral antibiotics, all right, versus not using any bowel preparations at all. And what they found was that if you combine bowel preparation with mechanical cleansing and oral antibiotics, this would result in a significantly lower incidence rates of infections, anastomotic leaks, hospital readmissions, all right? And progressing a couple of years later, they collected about 27,000 patients, and their study did confirm their earlier analysis that combining oral antibiotics with mechanical bowel preparation did significantly reduce the rate of infectious complications. Now, this is the basis of why the American Society has said that you need to give mechanical bowel preparation with oral antibiotics. However, the proponents in Europe who have extensively opposed the use of mechanical bowel preparations, particularly in colon cancer, they perform a few studies, and this is a very big meta-analysis looking at 36 studies of about 21,000 patients. And they saw all the studies that were looking at mechanical bowel preparation versus no mechanical bowel preparations. And you can look here how many of these were randomized controlled trials and how many were not. And if you know about the forest plot, and these are the forest plot looking at the overall surgical site infections, and when they put all the studies together, it is really whether you use MBP or not, it does not affect overall surgical site infections. It does not affect the rate of intra-abdominal collections. It does not significantly cause an overall increase in the hospital stay, and neither does it significantly affect mortality rates. Now, the latest review in 2020, which was done by the French group, also concurred with the earlier meta-analysis that state that all these randomized controlled trials really favored no use of mechanical bowel preparations. What they did found is that it does favor the use of oral antibiotics alone. So in fact, what they concluded is that oral antibiotics alone was superior to no mechanical bowel preparation. And they went a step further and they analyzed the American results, and they found that the American studies did not really show a strong conclusion because there were many weaknesses in that studies. Now let's look closer to our region. As I said earlier, there is no Asian randomized controlled trials or meta-analysis done. But if we can look at our neighbors, you know, if you can look at our neighbors in Korea, for example, what they did, my good friend Suk-Hwan Lee, who is president of the Colorectal Society, they did an audit on the use of mechanical bowel preparations in Korea, and they found that about 98% of surgeons in Korea use mechanical bowel preparation and intravenous antibiotics. And more than half actually administered oral antibiotics in colorectal surgery preparation. So what about in China, where they studied a really huge amount of about 3,000 or 4,000 patients, and what they found was that the use of mechanical bowel preparation alone was generally higher in Chinese surgeons, right? And that most surgeons would prescribe some antibiotics. So generally in Asia, you can see that we're still using mechanical bowel preparations as a. What about in Malaysia? Now, a very quick Google search has shown that there are some studies on mechanical bowel preparations. For example, here by Atta Qureshi, all right, and also by and some of the gastroenterologists. But what generally the studies that have been done in this country is mainly on colonoscopy. For surgery, there's really not enough studies, and maybe we should be doing our own national audits. So which one should we choose? There's really no wrong and right answer. It depends on whether you agree with Americans or whether you agree with the Europeans. My personal preference is that I do not use mechanical bowel preparations in the colon. I only use mechanical bowel preparations and oral antibiotics for rectal cancer surgery. So that's all. Thank you very much. And I'll be happy to take your questions at the end of the symposium. Thank you.